So, so after the last two discussions on gene therapy, the first one by Dr. Bilal, where he discussed on Casgevy, which was a modality of gene editing in transfusion-dependent thalassemias, where they, by the way of CRISPR-Cas9, they had edited the one part of the beta globin gene, especially the erythroid enhancer region in the beta globin gene, and then these hematopoietic stem cells um, uh, were transduced with this vector and then infused into the patients, and it had very good results with around 90%, more than 90% patients showing transfusion independence. And the one which I had presented was on gene addition, so wherein the wild type beta globin gene was inserted into the vector, and this vector was transduced into the hematopoietic stem cells, autologous, and then infused into the patient, which also had very good results. So, these are the two major trials and the two major modalities of gene therapy in beta thalassemia. So, I'll just and now today we'll be discussing the other trials. Uh, So this is basically a diagram which is showing the first part of the diagram is showing gene addition, where we can see the beta like globin gene is in the vector, and this is transduced into the stem cells. The B part is showing the Casgevy modality, that is the CRISPR-Cas9 base editing. So the erythroid enhancer in the beta globin gene has been edited so that there is BCL11A in the BCL11A gene, and there is decreased manifestation of the BCL11A gene. And the C part, so the C part is basically it is the gamma globin gene promoter region. So there are different types. So the first one is showing the KLF1 motif. This is edited. Then the next is the TAL1 motif, and the last is the GATA1 motif. So these motifs are basically the gamma globin gene promoter regions. So if by editing these regions, we can decrease the BCL11A gene expression and increase the HbF percentage levels in the blood of the patients, and hence these beta thalassemia patients can have a much more functional hemoglobin and lead to transfusion independence. So the rationale, in detail, if we want to look at the rationale, so the hereditary persistence of fetal hemoglobin is a benign condition associated with elevated HbF levels in adulthood. So when HPFH occurs in individuals with beta thalassemia, the beta-like fetal gamma globin compensates for the lack of beta globin expression, reducing the level of morbidity. So there is increased HbF, and hence the patients can be less transfusion dependent. So HPFH can result from large deletions in the beta globin locus. So this is one way. And the second way is point mutations clustered in the three regions of the homologous HB, G1 and HB, G2 promoters located on these base pairs. So either of this can be used for gene editing. These mutations basically alter the binding sites of transcriptional repressors such as BCL11A or LRF. So BCL11A is the most commonly targeted one, and it creates the binding sites for transcription factors that upregulate the gamma globin, that is basically upregulating the HbF levels in the blood, like we saw in the previous diagram. So, so this is a summary of the clinical trials on gene therapy in beta thalassemia. The first one, the Beticel, is the gene addition one, which is already discussed in detail. The second one, which I'll be discussing today, is the Globe lentiviral vector. It was done in Italy. The next one is the TNS 9.3. This is again a gene addition trial, which is done in MSKCC. However, the results were not really good. We will see the reasons for that. And then in gene editing, the two main trials are the ST400. It has just completed the preclinical phase and it has enrolled, I think, around 3 to 4 patients. So we don't have a very robust data. We have a limited data, which I'll be discussing in the subsequent slides. And this is the last one is the Exacel, which is Casgevy, which was also already discussed by Dr. Bilal in detail. So this is a zinc finger nuclease modality. So genetically modified autologous stem cells in the laboratory using so this is basically the ST400. This is the gene editing type of gene therapy. So the autologous, so the autologous stem cells are edited in the laboratory, are transduced with this zinc finger nuclease technology to disrupt a precise and specific sequence of the enhancer on the BCL11A gene. So preclinical studies have shown good results. So the results of this study, 3 patients have completed the ST400 manufacturing, 2 have been infused. So they also received the busulfan conditioning similarly as we saw in the previous studies. So patient 1 received a dose of 6.1 into 10 raised to 6 cells per kg, which was quite less compared to what we had seen in the earlier studies. The patient had prompt hematopoietic reconstitution, ANC recovery in around 14 days and platelet in 24 days, which is good compared to the previous studies. And with increasing HbF fraction that contributed to stable total hemoglobin. So he was transfusion free for the next 6 weeks. However, after that, the patient has had requirement of intermittent PRBC transfusions. However, one thing to note is that he had severe hypersensitivity during the after the infusion. But by the end of the trial, that by the end of around I think 3 to 4 days, he was he had recovered. Then patient 2, he received 4.5 into 10 raised to 6 cells per kg. Again, here also the engraftment was good. ANC by 15 days and platelet by 29 days. And there was increase in the HbF levels. However, there is no mention of whether he was transfusion independent or for how long he was, because this is a very new trial and the results have been published only in the abstract form. We don't have a complete trial. We don't have a complete trial document available. And in the second patient, there were no adverse effects, no serious adverse effects. And this is the gene editing one. Coming on to the gene addition. So MSKCC had done this study in 2017. So it's quite an old study. It was a phase 1 study. They had and this is a 6 to 8 follow-up of the 4 adult patients who were infused. So they included only adult patients. In the previous study, also only adult patients were included. So this is this TNS 9.355 lentiviral globin vector, which has the beta-like globin gene. So wild type beta globin chain under the erythroid specific transcription control of the human beta globin promoter and 3 segments of the locus control gene. So this was a wild type beta globin gene which was through the lentivirus transduced into the hematopoietic stem cells. So the participants were 18 years or older, diagnosed as beta thalassemia major, that is more than 100 ml per kg per year for at least 2 years. And patients with HLA match siblings were excluded because that was the preferred modality of treatment. Patients' eligibility included adequate organ function and a performance score of more than 70%. So they received GCSF at a dose of 10 mics per kg once daily subcutaneously for 6 days. And on the morning of the 5th and 6th day of the GCSF treatment, the apheresis was done. The goal of collection of the stem cells was 8 into 10 raised to 6 per kg. So these are the patient characteristics. So as we can see the age, the youngest patients were 18 years old. The oldest was 39. There were 2 males and 2 females. All were severe. Although we can see beta 0, they have mentioned that in the molecular, that the beta 0, the molecular which was there, it was a severe variation. So transfusion requirement was high. And one of them was plenectomized, patient 2.
Plenectomy is not a contraindication.
It was not a contraindication here. So patients 1, 2, and 3 received busulfan conditioning. Dose was 2 mg per kg per dose. In patient 4, they have mentioned that they had reduced the dose based on the pharmacokinetics of the busulfan in the first dose. So he received slightly a lower dose of 0.8 mg per kg per dose. So as we can see, number of CD4 collected was around 30 in the first patient, 10 in the second patient, and the fourth patient required two apheresis cycles. So the median was around 16. The drug per product VCN. So as we have seen all these studies of gene therapy, one thing that we can conclude is that the drug product VCN is extremely important in knowing whether the patient will respond to the gene therapy or not. So here we can see it was quite less compared to what we had seen in the ZYNTEGLO trial. So it was around zero point 0.7 to I think 1.7 to 1.1 in the ZYNTEGLO trial, while it is only 0.15 here. So this was an older trial. Maybe that time they were not aware about this.
In fact, there is a study which has correlated the viral copy number
Yes,
and
ma'am.
the outcomes, and then they realized that you need to have a particular level.
Yes.
Then the sustainability, you may immediately get transfusion independence, but the sustainability is not good if you do not have good BCM.
So they will relapse basically
Yeah, they will
in some
relapse.
time.
So that's important point you brought out.
So the CD4 in cell infusion dose. So if you can remember, it was very high in the ZYNTEGLO study. I think it was median was somewhere around 15 to 16 into 10 raised to 6 per kg. Here it was around 9 into 10 raised to 6 per kg. So neutropenia occurred on day 11 and persisted for 8 days, and engraftment occurred on day 19, which was good compared to the earlier studies. And thrombocytopenia was there, occurred on 3 patients on day 11 and lasted for 6 days with engraftment at around 19.5 days. Similar. So this is also good. So the VCN per diploid genome was measured by PCR in the bone marrow as well as in the peripheral blood. So points of discussion, that the none of the patients had reached a durable transfusion independence. Like ma'am mentioned, maybe they were transfusion independent for some time, but they relapsed and they did not have a durable result. So what they have said that the cell product size and rapid engraftment after conditioning argue against cell dosing. So although the cell dose was low, they are saying that the cell dose may not be the reason for this relapse of transfusion dependence. So in summary, what they have concluded is that the drug product vector copy numbers of 0.15 was not sufficient to achieve the transfusion independence. And the other studies have shown that a DPVCN of at least 0.3 is needed in patients with mild genotypes. So in in more severe genotypes, we might require even a larger and a higher VCN. So coming to the next trial, that is the GLOBE trial. This was a phase 1-2 study which was done in Italy. It used
intraosseous, no?
Yes, yes.
Intraglobe.
Yes. So GLOBE trial. So it was a third generation self-inactivating lentiviral vector encoding for the human beta globin gene. Again, this is a gene addition. Patient undergo conditioning regimen based on the myeloablative triosulfan and thiotepa. I tried to find the doses, but however, I could not find them. I searched a lot online. So here, the things to note are the conditioning used was not busulfan, it was triosulfan and thiotepa, because they thought maybe by using this, we will have a faster engraftment, more efficient engraftment, and reduced extramedullary toxicity. And here another thing is the route of administration was intraosseous and not intravenous. It was done in the posterior superior iliac crest with the aim of enhancing engraftment and minimizing the first pass intravenous filter.
But I think they had very good outcome in pediatric patients.
Yes, these
but
not in
adults.
adults. Yes, ma'am.
So I remember this study
Yes.
because I have quoted in my presentation in
Right,
my
ma'am.
talk.
So, yes, ma'am. So, till now, 9 patients have been enrolled. Out of that, 3 were adult, like more than 18. 3 were in the adolescent and older children, that is 8 to 17, and 3 patients were children, that is 3 to 7 years of age. Transfusion dependent beta thalassemia of any genotype they had included, and the criteria was that they should receive at least 8 transfusions of blood per year over a minimum of 2 years. And again, performance score was should be more than 80%, and age more than 3 or less than 65, and adequate organ functions. So results, the CD4 cell dose was around 16 into 10 raised to 6 to 19.5. So again, the cell dose was much higher compared to the MSKCC trial. Vector copy number was 0.7 to 1.5. Again, it was much better. Median follow-up was 13 months for a few patients. Procedure was well tolerated with no evidence of with no product related adverse effects like we saw in the initial trial, in the first trial of gene addition where he had hypersensitivity. So there was no product related adverse events. No evidence of replication competent lentivirals of abnormal clonal proliferation. So median time to neutrophil engraftment was around 19 days and platelet engraftment was 15 days, which is a bit odd, na? Platelet usually late hona chahiye, late
No,
hota
but
hai.
in some of these gene therapy trials, we have seen that there can be a discrepancy.
So here the platelet was earlier and the ANC was later.
Some HSCTs also we see platelet engraftment first.
Okay. So 3 adult patients had a reduction of transfusion requirement but are still transfusion dependent. So the last follow-up was around 2 years, 18 months and 16 months. Among the 4 pediatric patients, 3 have discontinued the transfusion shortly. So again, pediatric patients have shown a much better result. So we can say just like in transplant, earlier we do the gene therapy, maybe better because they'll be much better.
It has similar connotation. We don't understand the logistics.
The rationale may be different.
Whether the rationale is more of, their marrow is still pliable. The niches are still, ready to adapt to the new HSCs which you are putting inside, and you are directly putting into the bone. So there was a discussion in this paper, I think, if I'm not forgetting, Intraglobe Italian trial, that pediatric niches are better to accept these cells, and therefore maybe pediatric outcomes were better. But that is a disadvantage because ideally, gene therapy, we want to not keep it limited to pediatric age.
Right. We want to give it to people who are not eligible for transplant.
So that is a flip side of this logic.
One bone only, no? Posterior.
Yeah, yeah.
What about other?
But no, but it will spread, no? The cells will go
May
and.
be better then. IV route may be better.
Yeah, maybe. We don't know. We don't know. IV is, of course, superior probably. This was one of the methods.
Yeah, and it
they
was
tried.
just 9 patients. So, I mean, 4 pediatric
And I
patients
think
only.
they're looking at long-term follow-up.
Yes,
still. They have
yes,
not
ma'am.
included more
They
patients.
plan to follow up for 6 years at
Yeah.
least. So, among the 4 pediatric patients, 3 have achieved transfusion independence, and 1 pediatric patient is still receiving regular blood transfusion.
So 1 out of 4 only failed. Whereas in adult, there were 5 and only 1 became completely transfusion independent, if I remember the result.
Yes,
correctly.
ma'am. Out of 4, 3 are transfusion independent and 1 is still.
No. In the adult ones, only 1 became transfusion independent out of the 5. Rest 4 remained partially dependent.
Ma'am,
Whereas
yes.
in pediatric, it was ulta.
Ulta. So toxicities, serious adverse effects were seen in 4. Most of them were related to infections due to the conditioning regimens. So FN, acute pancreatitis, gastroenteritis, device related, that is catheter related, and mycobacterium infections were seen. And non-serious adverse effects were seen in all patients. Pyrexia was the most common, seen in 5 out of 9. Asthenia, weakness, fatigue. Peripheral edema was seen in a few, and hypotension was seen in 1 patient.